If health is wealth, then AI is helping us get richer. From improving clinical care to empowering personal health monitoring, AI-driven solutions are taking part in changing the way we get and stay healthy. AI has found itself into different aspects of health and wellness. From molecular diagnostics and genetics to radiology and orthopedics and even mental wellness, AI is revolutionizing healthcare services in ways we can never imagine. AI's role in the Philippine healthcare system continues to grow, as medical services are pushed to be better and more accessible to the Filipino public.
I have no conflict of interest to declare for this presentation. But prior to the pandemic, I had the privilege of working with Mental Health PH on a Twitter chatbot called Kapwa. So Kapwa was a menu-based chatbot which could be accessed via Twitter direct messaging. And Kapwa was meant to assist those looking for mental health support or services on Twitter. So that was pre-Chat GPT, and much more is possible now with large language models, and mental health remains a concern for many. While Kapwa catered to anyone who needed mental health support, Efren, the Filipino diabetes distress chatbot that my team will be building, will have a narrower use case. So living with diabetes is challenging, and diabetes distress refers to the emotional response of living with diabetes, the burden of relentless daily self-management, and the prospect of its long-term complications. So greater diabetes distress has been associated with adverse outcomes, including reduced physical activity, less healthy eating, not taking medications as recommended, less frequent self-monitoring of blood glucose, elevated HbA1c, and impaired quality of life. Not managed properly, diabetes distress can lead to diabetes burnout, which is a state of physical and or emotional exhaustion with dealing with the diabetes. So this is even more worrisome, as such a person with diabetes burnout will disengage from self-care tasks, skipping insulin, not monitoring blood glucose, or engaging in risky behavior such as uncontrolled eating or missing clinic appointments. So the 7A's model is recommended to identify and support persons with diabetes distress. First, be aware that people with diabetes may experience diabetes distress. Ask about the diabetes distress. Assess for diabetes distress using a validated questionnaire. So these are the first 3 A's to identify. The last 4 A's are meant to support those experiencing diabetes distress. So the third A, as I said, is to assess for diabetes distress using a validated questionnaire. And commonly used validated questionnaires are the problem areas in diabetes scale and the diabetes distress scale. So the paid scale has 20 items. Each item is scored on a 5-point scale. And any item with a score of 3 or more indicates a problem area, which should be further explored. So the diabetes distress scale, on the other hand, has 17 items, and it has a 6-point scale. So why a chatbot? So I am an internist and endocrinologist. I know firsthand that physicians may have limited time during a clinic visit to assess for diabetes distress. The scales have 17 to 20 items. And second, patients may not expect to be asked nor wish to talk about their emotional state. And for the diabetes distress scale, there are actually questions about the physician because the physician can be the source of the distress. So for example, do you feel that your doctor does not know enough about diabetes and your care? Do you feel that your doctor does not take your concerns seriously enough? Do you feel that you do not have a doctor that you can see regularly enough about your diabetes? Can you imagine how awkward that would be if I had to ask my patient those questions? Hence, the general objective is to design, develop, and evaluate a Filipino conversational agent to assess diabetes distress. For the design, the specific objectives are to define the goal of the chatbot, create the conversational agent's identity aligned with its purpose, and to select the delivery interface. The goal of EFREN is to assess a patient's level of diabetes distress. If you're wondering, EFREN is a play on the words, a friend. So if I have to explain that, hindi nyo alam yung joke. Kung si Efren ay a friend from another star, paano kaya siya makipag-usap sa ating pasyente? What personality will it have? I remember for Kapwa, we had one pathway where Kapwa delivered corny Filipino jokes. So for the delivery interface, we were thinking it will be web-based, just like ChatGPT. So for development, determine the response generation architecture, develop the content, and build the conversation flow. From my experience helping to develop Kapwa, the Twitter mental health chatbot, it was complicated, trying to map out the possible conversation scenarios, even if Kapwa only had a hamburger menu and a very limited set of very defined conversation pathways. The methodology is, of course, different now because we have large language models. So for evaluation, assess the acceptability of the chatbot's questions and responses, assess the chatbot's usability. And for me, evaluation will be the most challenging part in deploying a chatbot for healthcare. If I were to use the 20-item paid scale at my clinic, I just cannot rapid fire ask the 20 questions. I cannot do that. I have to build rapport and empathy. I cannot be looking at the clock, even as if, it will extend the consultation. And there are physicians who have told me, AI can never replace a physician's empathy. Well, that may be true. I don't know if you will agree with me that chatbots can simulate empathy. And physicians are actually at a disadvantage because a chatbot is always available, it is never tired, it's never hungry or frustrated. So for the methodology, we intend to use a convergent mixed methods design with semi-structured interviews and self-administered questionnaires for persons with diabetes consulting at the Philippine General Hospital and the internists and endocrinologists taking care of them. I would like to know, what do persons with diabetes expect from EFREN? Would they feel comfortable discussing their emotions with the chatbot? How much of a barrier would typing their responses be? How about the internists and endocrinologists? How would EFREN fit in the workflow? If EFREN will only assess for diabetes distress, how will the patient's score be communicated to the doctors? What happens next if a patient is identified as having diabetes distress, and what support services will be offered? So where does AI come in? So to develop the chatbot, we plan to have multiple large language models with retrieval augmented generation for assessment. Multiple response generation strategies will be tested, and the chatbot's performance will be iteratively evaluated, not only by the patients, but also by the physicians. So to end, I will have to discuss nuances in designing, developing, and evaluating a chatbot for healthcare. In conceptualizing a chatbot for mental health, we need to specify the niche, the intended use cases, and determine the desired outcomes or objectives of each use case. We need to be particularly careful in healthcare because patient safety is paramount. We need to demonstrate success, perhaps in quite narrow use cases first, before we can begin to think of broader use. So we also need to evaluate the availability and accessibility of relevant healthcare data needed to train the LLM. Let me tell you, as a physician who has worked with computer scientists, when I ask them, how much data do you need? They tell me, as much as you can get. Okay, so there is no sample size. So there is one proof of concept study which used the RASA toolkit to create a diabetes distress chatbot. And the natural language understanding pipeline by RASA was trained using 50 examples of stories of distress, which were obtained from persons with diabetes and people who know persons with diabetes. Now, EFREN is a Filipino chatbot. Conceivably, our diabetes distress stories might be different. For example, here, insulin users are stigmatized as malala na or naging pabaya kaya naka-insulin. We have to engage with domain experts, maybe not only patients and doctors, but possibly diabetes nurses, diabetes educators, pharmacists who may know these diabetes distress stories. So EFREN is a patient-facing chatbot. So first, do no harm is what we learn in med school. So the Spirit AI checklist has guidelines for clinical trial protocols for interventions involving AI. So this guideline requires that researchers explain the intended use of the AI intervention in the context of the clinical pathway, including its purpose and its intended users. So in the 7A's approach, EFREN will only be doing the third A, the assess for diabetes distress using a validated questionnaire. And even so, we will need to work with both patients and physicians taking care of them as to how EFREN can be fully integrated within the 7A's pathway. So the Spirit AI checklist also requires that researchers describe any pre-existing evidence for the AI intervention and also to state the inclusion and exclusion criteria at the level of the participants. So in literature review, I only found one clinical trial of a diabetes distress chatbot. And in that study, 156 persons with diabetes received a social health program intervention in 3 sessions over 3 weeks. They were randomly assigned to receive support from either a chatbot or self-help text from a book called Diabetes Burnout. So participants completed the diabetes distress scale before and after the intervention. And according to the results of the study, participants in the chatbot group had greater reduction in diabetes distress. However, I thought that that comparison was quite unfair, a chatbot versus a self-help book. So lastly, evaluation. As a clinician, we have been trained to look for clinical outcomes. And so in the clinical trial I just described, the chatbot was evaluated according to its ability to reduce diabetes distress in comparison to a control group. But from the technology side, there must also be a framework to evaluate chatbots. Hence, Barletta et al. Proposed using the measures from ISO IEC 25010 standard. These measures include effectiveness, the accuracy and completeness with which users achieve the specified goals, efficiency, the resources expended in relation to reaching that accuracy and completeness, but not only effectiveness and efficiency, but also satisfaction, which have the following subdomains: usefulness, trust, pleasure, and comfort. So usefulness, the degree to which a user is satisfied with their perceived achievement of pragmatic goals, including the results of the use and the consequences of use. Trust, the degree to which a user or other stakeholder has confidence that a product or system will behave as intended. And pleasure, the degree to which a user obtains pleasure from fulfilling their personal needs. And comfort, the degree to which the user is satisfied with physical comfort. So freedom from risk, which requires mitigation of economic, health and safety and environmental risk. For me, the most important as a physician is freedom from health and safety risk, which is the degree to which a product or system mitigates the potential risk to people in the intended context of use. And lastly, context coverage, which includes context completeness and flexibility. So for EFREN, not all stressors can lead to diabetes distress, will be in the validated questionnaires. So EFREN might need to have some flexibility of asking open-ended questions to identify other causes of diabetes distress. So we are currently looking for funding for EFREN at the moment. With me is an interdisciplinary team from the University of the Philippines Manila, composed not only of computer scientists, but we also have a linguist who is an expert in natural language processing, and we have a nurse with expertise in health informatics. Thank you very much.